and I see many of you are kind of bright and shiny faced, so I appreciate that. Dr. Britton was telling me that you guys usually break on the hour, and I will try to be as respectful of that as possible. I teach a 3-hour night course on Tuesdays on infant mental health, and like we usually go the entire 3 hours until they're like looking at me like, oh my God, and I'm like, oh yeah, you guys could leave and go to the bathroom, I suppose. So that's not about you, that's about me, because I just get to talking, and so I will try to be mindful of that hour break so we can just kind of get up and stretch. I wanted to tell you a little bit about kind of my background. I moved here 18 years ago from Indiana and was working on my master's degree at OU because it's the only master's of social work program in the state, so don't judge me for that, because then I went and got my PhD from OSU. So really anybody who's going to pay me to go to school, that's who I'm loyal to. It's fine. But I was sitting in one of my classes, and I'll be honest, it was a class that I didn't typically attend. And the professor made an announcement, and he said, I got an email from a parent who is looking for somebody to work with their child who has recently been diagnosed with autism. And I thought, well, that's interesting. I wonder what we'll be doing. I had some experience. I had worked in a church nursery, and we had a child come through that was on the spectrum, and I didn't know a lot about it, and so I reached out to this parent and started working with her 18-month-old, doing applied behavioral analysis, which we'll talk about. I worked with that particular child till he was about 5. I would have loved to have done more, but there were very few people trained, and this particular family, they were a little possessive of me, and so finally, after about 2 years of working with them, I was like, you know, I wonder if there are other families that maybe I could reach out to and work with, and she goes, yeah, we've been contacted, we just didn't tell you. I was like, okay, that's flattering. And so I started working throughout the Norman community with different families, doing ABA and supporting children on the spectrum throughout my undergraduate and my master's program. When I graduated with my MSW, and I started working in community mental health. And again, I was sent all the cases with autism. Now, my role kind of changed because I wasn't doing ABA, wasn't doing that discrete trial training. I was really supporting families and wrapping their head around what this diagnosis was going to mean for their families. And so the presentation that I'm going to do for you today really incorporates 2 different things. One is I want you to be able to recognize it, but then I want you to be able to work with the family system and know who to refer to when you have a kid on your caseload who has this diagnosis. So as well as doing kind of autism spectrum work, I am also heavily involved in the infant mental health community here in Oklahoma. So I work with a lot of attachment disorders, children who come from hard places, who may be in foster care, things like that. And that's actually what I'll be pursuing now that I've finished my PhD. I've accepted a postdoc position with the University of Delaware, working on their attachment biobehavioral catch-up intervention, which is a program that Mary Dozier created to help repair disruptions in those early relationships. So I'm really excited. We're actually going to be modifying that intervention, which is now, there's an infant version, which is 6 months to 2 years of age for the child, and then a toddler version, which is about 2 years to about 4. But we'll actually be modifying that to do this model with pregnant moms who are addicted to opioids. So it's very, very exciting. If you have any kind of questions about infant and early childhood mental health, shoot me an email and I can send you some resources on that, because that's another passion of mine. So one of the first families that I worked with was a boy named Bo. And as you're going to figure out as we go through this presentation, No child with autism looks the same. If you have seen one child with autism, you have seen that. You have seen one child who has that diagnosis. And so Bo and I became very, very close. I was working in the school system. They had a pilot program where kids on the spectrum would go to a kind of typically developing preschool class, so they got that exposure to healthy development. And then the second half of their day, we would do more of that kind of one-on-one teaching that children on the spectrum need. So he was in my class. His parents were interested in expanding his program, and I would pick him up from his childcare center, and we would do some discrete trials. We expanded that work to actually do some community work. So I would do things like take him grocery shopping with me, so he could kind of go out in public and not feel so overwhelmed, and support him through that. Bo was in kind of special education classes throughout school. He had different paras at different times supporting him, so his day was kind of split 50-50, where he was in special education classes, but then he also attended regular classes as well. In high school, he got into band, and this was a great thing for Bo. So you'll see this picture right here is him actually in the drum corps in, I forget which Norman high school it was. Thank you for knowing that. I can never keep them straight for whatever reason. And so that gave him a social group. They protected him. He was actually nominated and won homecoming, Prince, whatever, 3 years in a row, and was nominated his senior year but did not win. So that's the kind of support that he was given, because he was put in this kind of typical kind of extracurricular class with kids who really wrapped around him and helped him. A funny story, Bo is kind of naturally charismatic. You can see he's kind of a good-looking kid, right? And so he's got that working for him. He actually taught the entire band the song Beer Run, which did not go off very well with his teachers, but I thought was hilarious. And so the prevalence of autism has really gone up in the last few years. So when I started working with this population, it was about 1 in 1,500, 1 in 1,000. The numbers were kind of mixed. In 2010, that number had grown to 1 in every 68. Now, there's lots of speculation as to why the numbers are what they are and why we've seen this huge increase. What are some of the things that you all have heard about that may be leading to this rise in diagnoses? Say it again?
Advanced maternal age.
Yes, advanced age, absolutely. What else?
It's more inclusive than it used to be.
It is. We're going to talk about that it's a spectrum and more symptomology is being included, so therefore more kids are falling on that spectrum. What else? Yeah.
More awareness.
There is. There's generally more awareness. How many of us watched Parenthood and saw that whole transition of that family dealing with a child who I think at first was diagnosed with Asperger's? We've now gotten rid of that diagnosis, and we'll talk a little bit about that today. So there's just generally more awareness. So, you know, when I was in high school and the kid who really didn't fit in and had trouble in social situations, but was really, really smart, maybe he, you know, got involved with IT and computers and things like that, may actually have that kind of diagnosis today. Whereas back when I was in high school, he didn't necessarily have that label. And that's, I mean, good, bad, or ugly, that's kind of what is happening. So what do you all know about autism spectrum disorders? What what do you think of? Many of you raised your hands when I brought up parenthood. What do you all think of when you think of an autism spectrum disorder?
It has a lot of sensitivity to like sound and touch.
Yeah, sensory issues are kind of incorporated with that. A lot of times they'll have sensitivities to tags on their shirt, or their socks have to be a certain way, or they'll only wear a certain type of clothing. Yeah, certainly. Their bodies just seem to be a much more sensitive to more typically developing children. What else? Yeah.
They can get overwhelmed by social situations or interactions.
Absolutely. Social situations are really overwhelming for them, which is kind of understandable, right? Because every social situation that children, or anybody kind of interacts with is different, right? How I'm interacting with you all today is going to be different than how I interact with my friends when we go out tonight. I don't go out. That's a lie. I'm still in dissertation hangover. Right, every interaction is different, and so that becomes very overwhelming for them. What else?
They're usually really good at one subject in school.
Yes, they typically excel at one subject. We hear that a lot. We hear that children on the spectrum may have a savant syndrome, maybe very good at math or something like that. And that's not always the case, but we hear about that a lot. What else? Yeah?
My brother-in-law is autistic, and you have to stay to his schedule. Like,
Okay.
He has a very strict schedule.
Yes.
You have to happen on time and in a certain order and
Right.
what he expects.
That flexibility is really hard, isn't it? To kind of roll with the punches. They like to know what's going to happen, when it's going to happen, and that happens in a specific way every single day. Absolutely. So there are lots of things that we kind of hear. We hear this kind of savant, we hear, they can't make eye contact, they struggle in social situations, that they may have sensitivities. But what really constitutes a autism spectrum diagnosis? So this is the official DSM diagnosis. I apologize that it's so small. But I wanted you to just kind of get a feel. There's lots of, we're gonna parcel this out throughout our morning. So the highlights is that it's biologically based as a neurodevelopmental disorder. It's generally characterized by two major domains: communication and interaction, which you all mentioned, and then restricted repetitive patterns of behavior, interests, and activities. When I was working with kids on the spectrum, I knew everything there was to know about Thomas the Tank Engine, because it seemed like every child that I encountered on the spectrum loved Thomas. They all had the train set up. We would go to the library. That was the only thing that they wanted to do, was to play with the train. And so it is this restricted kind of patterns of behaviors. We've gotten rid of some of the other diagnoses, and we've now kind of called this a spectrum disorder. And so you'll notice in the DSM, when making a diagnosis, that you have to rate the severity index. So level 3 requiring very substantial support, so this may be that they have to live in some kind of residential setting or with other caregivers, having to kind of meet their daily needs. Level 2, requiring substantial support. I would put Bo in this category. He's currently living with his grandparents in Dallas because he is attending the Non-Perel Institute, and I'll talk a little bit about that a little bit later in my presentation, but it's this really cool program that's down in Dallas, and that's where his grandparents live. His parents live in Norman still. so in order to get him access. He can't drive. He is able to kind of cook and take care of his basic needs, but some of those larger needs, he still needs some substantial support around. And then level 1 requiring just some general support. So there are people on the spectrum who can live independently and take care of their own needs. So I really like this visual about autism spectrum conditions. So we have over here this kind of high functioning, what used to be deemed Asperger's syndrome, where we see these extreme abilities, but yet a lack of social context. When I was doing community mental health work, I had a child on my caseload that had functioned really, really well in school, in his relationships, until about age 11 or 12. And as his social kind of obligations increased, he started to decompensate. So in early elementary school, where it was very kind of teacher and adult driven, he did very, very well. But then as he aged and those peer relationships became more important, he started to decompensate because he just couldn't handle it. His anxiety went up. We saw a lot of kind of physical picking of the skin, chewing of the nails. He would pull out his eyelashes, things like that, because of the anxiety around these social constructs. One of my favorite stories about him is he would get bullied a lot in school. And so he was in my office one day and we were talking about it, and he said, you know, I was walking down the hall and I just called this guy a jerk. And I'm like, well, we can't just call people jerks. Well, he is a jerk. Like, he was walking in the middle of the hallway. I mean, I wasn't lying. And I'm like, oh. I mean, it was very kind of this classic black and white response to these peer interactions. So he was very much on this side of the spectrum, extremely intelligent. In fact, at the time I was working with him, I was getting ready to sit for the GRE. And I thought to myself at one point, wow, I should really look into him taking the GRE for me, because even at 13, I think he could do better on it than I could at this point in my life. Because he was that smart. But socially, he was a mess. And then we have more of that kind of classic autism. One of the saddest situations that I encountered when I was working with this population was a child who had a very disintegrative form of autism. And it was very, very hard on the family. He couldn't wear clothes. Even at age 5, he was still in diapers. He was a big kid. And it was very hard physically to manage his behavior. He was very aggressive. He would tear paper, and so when I would go into the home, there was just kind of this layer of stuff on the floor that he had kind of torn up around him. So very, very hard. His particular form of autism, he probably was never going to live independently, unfortunately. And then we have everywhere in between. We have kids with just kind of average IQs that struggle a little bit socially, that need some of that additional support. You know, we have kids like Bo who have kind of that mild to moderate learning disability struggles, but has found kind of his niche and has found a way to survive. These are some of the diagnoses that have been on the spectrum before. More than likely anymore, if you have a child that comes to you already with that diagnosis of an autism spectrum disorder, you're going to see more of that DSM ASD with the severity index. These diagnoses have really fell by the wayside. Again, good, bad, or ugly. That's just kind of where we are. So the clinical features that you're going to see are that impaired social communication. So that's social reciprocity. When I ask you all a question, you all give me some sort of response. That back and forth social exchange is very, very hard for kids on the spectrum. Joint attending. So right now we are engaged in joint attention, right? I'm focused on this slide, you all are focused on this slides. Hopefully none of you are shopping on Amazon, although if you find any good deals, shoot me an email. They struggle with reading, nonverbal communication. One of the very first signs that a child may be struggling or may be on a path for an autism spectrum diagnosis is the lack of pointing. I heard some of you talking about some babies in your lives. That's one of the first things we see from children is this joint attention, the child pointing and the caregiver looking to where the child is pointing. With kids on the spectrum, this is one of the first indications that there may be something wrong, is that lack of pointing, that lack of joint attention with a shared common object. Again, having trouble with social relationships. Social relationships are very hard, trying to distinguish how I communicate with this person being different than how I communicate with, say, my boss or somebody like that. We also see restricted, repetitive behaviors. How many of us have encountered somebody who fidgets? Yes, when I was completing my master's program, my best friend at the time would sit next to me and she would jiggle her leg to the point that it would shake the entire table. Now for you all, because many of you are taking notes on laptops, it's not an issue anymore. I swear all of my master's notes look like this, like I was doing it in an earthquake, because she had this general fidget, right? I see some of you twirling your hair. I see some of you biting on a pen or something like that. These are all physical kind of fidgets to get some of maybe some nervous energy out. Maybe you find my voice a little annoying or something like that. And so we all kind of have these, but for kids on the spectrum, it takes another persona. Some of the research behind fidget type behaviors, they had kids on the spectrum do self-portraits. And what they found were that kids on the spectrum, when they would do these self-portraits, they would look like this. So it was as if their limbs weren't connected to their bodies. So one of the hypotheses around fidget behaviors is that if I'm standing like this in front of you, I know that my hands are at the bottom of my arms, which are attached to my shoulder, which are attached to the rest of my body. I don't need to move to have that sensation. My brain automatically processes that. The hypothesis for kids on the spectrum is that they constantly have to be moving to get that sensation. And so that feedback from their extremities to their brain, they constantly have to be moving. I don't know if that's accurate, but it sounds pretty viable, right? So oftentimes you'll see kids, with fidgets in their hand. We've seen the cubes. One of my favorite fidgets is a string of wooden blocks that are connected that you can kind of manipulate and move around. This insistence on sameness is because the brain is pattern seeking for all of us, right? And so how many of us have had the experience of driving home the same way we always drive, and we get home and we don't really remember how we got from school to home, right? It's kind of an eerie feeling, right? That's because our brains are pattern seeking, right? And it's trying to get rid of any excess information. So unless there was something novel on this trip, the brain says, well, you don't really need that information. We're going to go ahead and get rid of it. And so for kids on the spectrum, they're constantly looking for that pattern so they know what to do, which really decreases their anxiety. Again, we talked about the restricted interest and some of that sensory perception. Some kids on the spectrum, they kind of have very intense feelings. And so if you just touch them on the shoulder, it feels like you punched them. Whereas others, they feel more, they require more intense touch to really, to feel that. And everywhere in between. Right now, your brain is filtering out all of this information that it doesn't need. So I often think about, what we see. You all your eyes are generally pointed in this direction, or you're intensely taking notes. But that means your brain has filtered out that we have two kind of different sources of light. We have some artificial light coming in from the hallway, but we have some natural light coming in from these large windows. Our brain is filtering out sound, so you can really hear my voice. We're not paying attention to the fact that the air conditioner is running and the projector is kind of making this humming noise. But I bet as I said that, you started to hear those things, right? Because we brought awareness to it. So kids on the spectrum, that filter is missing, right? So they're experiencing all of those different sensations in one. Their brain is not good at getting rid of information that it doesn't need. It's keeping all of it, which can be really overwhelming. I encourage you guys, next time you're at Target or Walmart, just kind of go to a really busy aisle like the toy section and let all of that sensory input kind of flood you. It makes sense to why these kids really struggle in those kind of environments. Because they just can't filter out that information like we can. So early identification is really important because it's been found that with early intervention, some of those symptoms can be reduced, and we can help kids live kind of fuller, happier, healthier lives. And so autism can be identified as young as 3 to 6 months of age if you know what you're looking for. Typically, it's diagnosed more around that kind of 18 months range. Again, we do have situations where kids are identified later in life because it's more of a social problem. It's not the intelligence or IQ portion, so they've done well in school, they've done well with language, but when those social obligations become too much, that's when we see an increase in symptomology. So what kind of signs, for those of you who might end up in family practice, what kind of signs might you be looking for? So by 6 months, if you're not seeing or the caregiver isn't reporting big smiles or joyful expressions, that may be something to be concerned about. With infants, I often talk about that we want babies to have this kind of happy medium, right? We get concerned when babies aren't crying or aren't expressing needs, right? Because that could be an indication of an attachment disorder. It could be an indication of an autism spectrum disorder. We also get concerned about babies who are completely inconsolable and cry and cry and cry and cry, right? So we're looking for that baby to kind of be that happy medium, to cry out when they need something, but when that need is met, they do feel consoled. That they're smiling, that they're doing that joint attention, that they're starting to point at things within their environment, that they have that look of curiosity. So at 6 months, if we're not seeing that, or if the parent isn't reporting that when we're asking those kind of questions, that needs to be a little bit of a red flag. What could be the cause? Now, there are lots of different reasons why that may not be happening. One of which is the child has some kind of autism spectrum disorder. It could also be trauma, that child is coming from a hard place, or that there's some kind of disruption within that relationship. We also sometimes see some of that behavior with diagnoses like cerebral palsy and more physical ailments. And so again, that needs to be on your differential. By 9 months, if we don't see that back and forth sharing of sounds, where mom coos and baby coos back, that emotional dance that we see happen, if we're not seeing that, we're going to start to ask some questions. By 12 months, children should be responding to their own name. No babbling or baby talk. Now, at any point in time, if we see a regression of symptomology, we want to, or a regression in their development, we want to ask some questions about that. So the first family that I worked with that I told you about, he was developing fine at 6 months, at 12 months. But then at 18 months, things looked very, very different. Any language that he had, such as mama and dada, had completely gone dark. The light in his eyes had kind of gone out, according to his parents. He just wasn't doing that back and forth that they were used to anymore. They noticed this around the 12-month mark. It took about 6 months for them to get their pediatrician on board, that there was something going on. Now, I think today that would look very, very different, because this was 18 years ago. Please don't do the math on that. And so anytime we see a regression of development, we want to ask some questions, maybe even getting them into a developmental pediatrician to do some of that additional screening. By 16 months, if they have no spoken words, we want to be concerned about that. Now, if the child has language that only mom understands, you know, that kind of cup. Oh, when he says that, he's always pointing to the cup. That's okay. It doesn't all have to be intelligible. But that there is expressive language that seems to have intent. If that's absent, again, we want to ask some questions about that. By 24 months, again, if they're missing that meaningful two-word phrases, if they're not imitating throughout this, we want to be concerned about that. The American Academy for Pediatrics recommends that developmental delays be screened for at 9 months, 18 months, 24 months, and 30 months. Again, if you're doing a thorough well baby visit at 3-6 months, some of these signs are going to come out naturally, but I'm going to go over some of the more standardized scores as well. Now, several years ago, when I was getting into to this line of work, again, 18 years ago, because that first child I worked with just graduated high school, he his parents were concerned about the vaccinations and the vaccinations causing autism. I think that's pretty much been taken out of our understanding of autism. That particular scientist has been completely discredited. Those studies have never ever again been replicated, but occasionally you will hear concerns about vaccinations and its relationship to autism spectrum disorders. These are hard conversations to have with families because families feel very, very strongly about this association. And so I would encourage you to read up on those studies. And again, the fact that it's never ever been replicated in the 18 years that he was discredited. He did some bad research regarding this association. So again, one of the first kids that I worked with, his family was convinced because of when his symptoms started, again around that 12-month mark, when we get the MMR shot, right, and lots of those vaccinations, that there was an association. I have not talked to them recently to figure out if they still believe that. That would be a very interesting conversation to have. I found this flowchart on the CDC website because the numbers are so large for this particular set of symptoms. There are a lot of resources that are actually out there. And the Centers for Disease Control has a lot of those resources for free. And this is one of them. So it starts with a parent completing a screening tool in the waiting room. I'll talk about some options for that particular screening tool. The clinical staff scores and reviews it. If the scores are negative, again, we just go over the results, with the family. If they're screening negative, but there are still some concerns, it gives you some options to go over with families, such as providing some anticipatory guidance, maybe saying that we're going to go ahead and we're going to monitor his development. Maybe that means seeing them sooner in clinic again. Maybe that means referring them out to a program like Sooner Start, which we'll talk about. Or maybe that we're just going to rescreen next time to make sure that everything is on track. If the screener comes up positive, that we want to take immediate actions, that we want to discuss those concerns in a frank manner, but with kindness. Think about where those referral sources need to happen next. And then again, getting them involved in some early intervention activities as well. I believe this PowerPoint was put on your online learning platform, so these are all links where you can actually see some of these screeners. One of my favorites, and I think kind of a standard here in Oklahoma, is the Ages and Stages Questionnaire. What I like about the Ages and Stages Questionnaire is there are actually two different ones. One is just kind of an overall developmental screener that'll include communication, gross motor, fine motor, problem solving. But then there's also an Ages and Stages SE, which is social emotional development. So these screening tools give you some pretty specific things that the child should be doing. It's also rated as, yes, they're doing this particular activity, or sometimes they're doing it, or not yet. And I just really appreciate that kind of language with parents. Because even though a child isn't doing something today, doesn't mean that they're never going to accomplish that milestone. So again, it is just a screening form. it'll give you kind of a spectrum of where that child is at, again, overall, and then in those specific domains as well. It is for purchase. There was an initiative in Oklahoma, I believe the funding, I think it runs out this year, maybe next year, where primary care clinics, so family practice clinics, things like that, can actually get screening tools for free. And so if you call your health department, they would be able to give you some information about that. There's the communication and symbolic behavior scales. Again, this is more focused on communication, evaluation of developmental status. The in-chat is autism specific. So if you administer that, that's going to give you symptoms specifically related to autism spectrum disorders. It can be found for free online. So that's a really great resource. It is a little bit longer and can be harder to just give to a parent to do. So this, you may need a nurse's help or something like that to do it with families, especially if the family has a lower reading level or something like that. Whereas the ages and stages questionnaire is a little bit easier to administer. Some of the lesser known scales that you may encounter if you get a case that's already been diagnosed, that these kind of screeners may just kind of be in the child's medical record from a psychologist or a psychiatrist. So I'm not necessarily going to go over these, but I wanted you to be aware, so if you do have a child who pops up on your caseload and you see this in your chart, that you'll have a place to go with that. And again, these are all listed on the CDC websites. The ones that are free you can access from that site, so that's a really great resource. Kids on the spectrum, they need a team around them. You all as physician assistants will be thankful that that your particular patient has this team around them, because autism spectrum disorders are so multifaceted. So we want to make sure that we get their hearing checked, because hearing delays can emulate some of those autism-like behaviors. So we want to make that part of our differential diagnosis. Having access to a developmental pediatrician. These are sometimes hard to find, especially out in your rural communities. But if you can get the family hooked up with a developmental pediatrician, that can be a real asset to you. Sometimes there's a genetic counselor involved. The kid that I told you that was not diagnosed until 12, 13, 14, meeting his parents, I was like, okay, apples and trees. They're very, very functional people. They are leaders in their community. They're very, very rigid, and there's not a lot of flexibility. And I always just kind of wondered, what was your 12 to 13-year-old life like? And so there certainly is a genetic component to some of this. We know that kids on the spectrum often have trouble with fine motor skills and doing some of those self-care things. So having an occupational therapist can be very, very helpful. Obviously, communication is a huge part of this diagnosis, and so having a speech therapist, having a social worker on your team or access to a social worker can be very helpful in making referrals and helping families follow up. Again, having a team is great, but it's also a lot of people to coordinate. Yeah. Did you have a question? I'm so sorry.
No.
The child also might have a child psychiatrist or a child psychologist. A funny story about Bo is Bo was always a really kind of level kid. I started with him when he was 3. He wasn't a kid who threw a lot of fits. In fact, when he would get angry, I would actually get kind of excited because that was showing that he had a little bit broader spectrum of emotions. So that was actually a good sign. One of my favorite stories about him, I'm digressing, I apologize, but I had taken him to Target. And the rule was that I had to do my shopping before we could go look at toys for him, right? This is a very common parental practice. Then we would do kind of his work at Target throughout my grocery shopping, and then his break was to kind of look at toys and to play around and goof. Well, this particular day, he was not having that. And I had gotten all of my groceries in the cart, and he's like, "Toys now!" And I was like, "I don't know where this is coming from." And I'm like, "No, like we have 2 more rows to go, then we will go to toys." Very if-then, right? Pattern seeking. No, now. Really? And then he hit me, and I was like, "Oh, this is not going to. No." And I'm like, "Buddy, if you can't pull it together, we're gonna have to go home." Totally threw himself down on the ground. I mean, I was embarrassed because the other thing about Bo is like he's always been kind of a bigger kid. And so although he was about 4 or 5 when this was happening, he looked about 8. And so that's another kind of downside to having a child with an autism spectrum disorder is that Bo looks like this kind of typically developing normal kid. And so he looks like an 8-year-old who has thrown himself down on the ground in the middle of Target, falling out. And I'm like, "All right, you've made your choice. We gotta go." And so I leave the cart full of stuff and we go out to the car and he's kicking the back of my seat and just, hollering. We go home, he slams the door, which again, secretly I was like, "Yay." But then I was like, "Oh no, that's not okay." His mom comes home, what happened? So I tell her the story. I will tell you though, we never had a problem in Target again. The limit was set, he got the pattern, we were good. But I noticed over the next week when I had him in class that there was like more just kind of emotion and acting out and hitting. And I stopped his mom in the carpooling and I was like, "What is going on?" And she was like, "Well, we didn't want to tell you because we kind of did it as an experiment. But we started him on Strattera, which is an ADHD medication, to see if that might help with some of his attending." And I'm like, "Well, I don't know if it's helping with that, but all of these other behaviors have increased." Guess what? They stopped the Strattera in a medically regimented way, and all of those behaviors stopped. And so some kids need that, your ADHD type medications, stimulants, what have you, to help manage their behaviors. But as with any kind of psychiatric medication, it can exacerbate other symptomology. So it is recommended that, if a child is aggressive or has behaviors that are difficult to manage, that a child psychiatrist get involved to kind of manage some of those things. So as with all of our patients, we want to do a thorough developmental history. Asking questions about concerns about hearing, vision, and speech. That's the other really nice thing about the Asq Questionnaire is that it does have some of those open-ended questions for parents to fill in for you. We want to ask about eye contact and pointing. Oftentimes in retrospect, maybe you're not seeing the child until he's 3 or 4 years old. If you ask these kind of questions, the parents in retrospect will say, you know, he didn't make great eye contact, or we didn't have that pointing that I saw with my friends' kids. If we see repetitive behavior, some of that flapping or self-stimulation type behavior, unusual visual behavior. Bo tries really hard, even at 20, to make eye contact. But if he's having to concentrate really hard, we often see, you know, kind of his eye not being able to really focus in. I have never been a stickler for eye contact with any of the kids that I work with, and I think it's because of my experiences with kids on the spectrum, because that can be so difficult. And so getting their attention, but then not expecting them to hold that. Because again, the brain is having trouble parceling out what to focus on. So if the brain is having to focus on, I have to look you square in the eye right now, they may not be hearing everything you say, or they may not be able to follow those directions that you're giving. So being mindful of that as you're examining patients, that some people have a real difficulty maintaining eye contact, but that doesn't mean that they're not listening. We often see seizure history with kids who we have concerns about being on the spectrum, so that's something we want to evaluate for. I talked to you about the older kid that was diagnosed, and he had a lot of kind of self-harming or self-injurious behaviors. If he would get a scab, it would often get infected because he just couldn't leave it alone. The pulling out of eyelashes, things like that. Kids on the spectrum often have gut issues, so that's very common, so being mindful of that. There have been links between kind of gluten and bacteria. The first kid that I worked with, he was gluten-free. Before being gluten-free was cool, which was really challenging, and then casein-free, which is the protein in milk. So he would actually have potato milk. I didn't know that was a thing, for breakfast and things like that. If you have a patient who is on one of those diets, you also want to be concerned about other kind of vitamin deficiencies and things like that. The first kid that I worked with, in thinking about diet, is he was in a 40-hour-a-week ABA program, and I'll talk to you a little bit more later about what that looks like. And so I would be his first appointment in the morning, and we started about 8 o'clock. And he would have sessions all day long, every day. And so Monday, he would be a rock star. He would be getting all the answers right, just would be able to sit for long periods of time, just really concentrated. But then on Tuesday, it was like we didn't have a session on Monday. It was like he forgot everything. And we would see this kind of pattern. I started asking some questions like, what is going on? Because it doesn't seem like he doesn't know it. It seems like there's something blocking it. And so at first we started asking some questions about his sleep, right? I'm his first appointment in the morning. We know that sleep is really important. So maybe we push my appointment back to 8:30, give him an extra 30 minutes, and maybe that would help. No, that didn't do it. That didn't take care of that issue. We played with a couple other things, more maintenance work in the beginning before we introduced novel concepts. That didn't really take care of it. So we started looking at his diet. And it turned out that on mornings where he had more carbs, so when he had more of the gluten-free waffles and pancakes and things like that, he was a nightmare. Just really, really difficult. But on days where he had a little bit of protein with it, maybe he had an egg or some bacon or sausage, he was on fire and he would get all the answers right. So as you are starting to see patients and they're kind of maybe disclosing some of these behaviors to you, those might be some of the questions that you start to ask. What are his eating or sleeping patterns? Thinking about those kind of physical needs as well, and especially if they're on any kind of specialized diet as well. You want to ask about family history of autism spectrum disorders, language delays, anxiety, schizophrenia, and tic disorders as well. So of course, we want to monitor growth, muscle tone and reflexes, things that you're going to do in a typical kind of physical examination. But then you may need some ancillary testing as well, such as for communication, intelligence, their adaptive functioning, and then sensory motor evaluations as well. So we are about at 9 o'clock. This seems as good a stopping point as any. So let's just kind of take a 10-minute stretch break, get up, use the restroom, refill your coffee, and then we will resume.